later, which in turn can lead to failure of filtration and decreased IOP control. So if you want to do a cataract surgery after the filtering surgery, you may have to wait for 3 to 4 months after the filtering surgery. You make sure a pre-op low IOP, either use Diamox or mannitol preoperatively in addition to the anti-glaucoma medications. Avoid excessive massage after the block. Sometimes because of the mitomycin, the blood may very thin. So you have to be very careful. And leave the blood untouched. Temporal clear corneal phaco is better, and suture the cataract wound is also indicated, and use of NSAIDs post-op. Combined surgery, IOP lowering is better than cataract surgery alone and better visual improvement compared to filtering surgery alone. It also prevents the IOP spikes in the immediate post-operative period because already have done the blood filtering. It compared to two-stage procedure, the cost will be low, and post-op complications as in cataract surgery alone, and the success rate of trabeculectomy is low when you combine with the cataract surgery. So combined, what are the options? SICS trabeculectomy, phacotrabeculectomy, and phaco with mix. I don't have much experience with the phaco with mix. Phaco, you can do either a two-stage procedure or single-stage procedure, and two-site or single-site. Two-site approach, the visual improvement is same as single-site or two-site, but the less astigmatism will be less in case of two-site approach, and the IOP reduction may be more. But it takes more operating time and more endothelial cells loss is reported. So let us look at some case scenarios. This is a 56-year-old female who was diagnosed as a primary angle closure disease, which was incidentally detected 3 days back. So we don't have a baseline IOP, and the patient was already on Bimat and Diamox. So BCVA was 618, N18 in the right eye, AC was shallow, lens was showing cataractous changes in the right eye, both eyes. Pupil was showing RAPD in the right eye with the disc near total cupping. Intraocular pressure was 9 mm and 8 mm because the patient is on Diamox TID. Gonioscopy revealed closed angles. So patient underwent YAC-PI in both eyes, and post-PI IOP was controlled with a fixed dose combination of 2 drugs in the right eye and single drug in left eye, and the central corneal thickness was normal. So the lens was around NS2 to 3 cataract with a near total cupping, and the IOP was 10 mm post-PI, and the gonioscopy showed synechial angle closure around 180 to 270 degree. The fields were showing advanced damages in the right eye. So this was a case of advanced PACG with IOP control with 2 AGM with a significant cataract. So in this case, you can opt for a phaco with IOL alone because the cataract surgery alone will give you a reduction in the IOP, and maybe patient may not require these 2 anti-glaucoma medications in the post-op period. So the next case is a 54-year-old male who is a non-case of POAG since 2 years, and initially IOP was controlled with a fixed dose combination of bimetoprost with timolol, and on follow-up the patient's pressures were 20 and 21 millimeters in both eyes, and the disc was showing advanced damage in both eyes with an early lens changes. Gonioscopy, open angles. So we tried to add the medications, but the patient was not responding to adding medications, and the fields were showing over the progression, over the years, some progression in both eyes. So this was a case of both eyes, advanced POAG, IOP not controlled with maximum medical therapy, and the cataract is very early. So we can opt for a trabeculectomy with mitomycin C, both eyes, maybe left eye first, and then can plan a cataract surgery later whenever it is indicated. The third case is a 62-year-old male with diabetes and non-case of combined glaucoma post-PI 1 year. Patient was on bimetoprost eye drops. So on examination, the best corrected visual acuity was 615 N10 in both eyes, in right eye, and 612 N8 in the left eye. Cataractous lens in both eyes with a patent PI in the anterior segment. The disc were showing advanced damage. IOP was 48 millimeters and 46, and the gonioscopy showed open angles post-PI with few PIS. So we tried to add a fixed dose combination of 3 drugs. IOP reduced to 28 and 23 with maximum medical therapy. Fields were showing advanced damage. So this was a case of combined glaucoma, and the IOP was not controlled with maximum medical therapy. open angles, and there was a significant cataract. So in this case, you can opt for a combined phacotrap with mitomycin C under GVP. So my preference is cataract surgery with IOL implantation alone in case of lens-induced glaucomas, ocular hypertension, in open angle glaucomas with significant cataract. If the glaucoma is mild, IOP is under control with 1 or 2 anti-glaucoma medication, and the patient is well tolerated and compliant with the anti-glaucoma medication. In primary angle closure disease with cataract, if it is moderate glaucoma with mainly appositional closure, IOP under control with 1 or 2 AGMs and well tolerated with medication. Glaucoma filtering surgery alone in case of very advanced glaucoma, moderate to severe glaucoma in case of failure to achieve target IOP despite maximum medical therapy, if not tolerating AGMs or poor complying with AGMs with an early cataract changes. Combined surgery, visually significant cataract with moderate to severe open angle glaucomas with more than 2 AGMs, failure to achieve the target with maximum therapy, or not tolerating or complying with AGM. And if 2 surgeries at different times not feasible. Thank you.
Thank you, Dr. Manju. You've summarized all the points really well. I think.
I have one doubt. Like, is there any preference for any type of OVD during when if you're doing combined surgery, like dispersive, cohesive, if it is retained?
Maybe combined surgery, even if you need the cohesive in, I think it won't be a problem, because I usually use cohesive once the cataract is done. Then I put the cohesive viscoelastic to complete my trap, and maybe if I'm feeling it is shallow, I may need a bit of cohesive the inside, so that immediate post-op shallow will be less.
Okay. And then any change in the regime of steroids that you give postoperatively if you're doing a combined case compared to normal cataract?
Yeah, whenever you are combining with the filtering surgery, I think you need a